Good morning, good afternoon, and good evening. I'm Constanza Moreno Fernandez, and I'm happy to facilitate the following two conferences for Africa region. Thank you to each of you for being with us today. We hope that you and your families are safe during these uncertain times in the middle of the COVID-19 pandemic. On behalf of the International Society of Pharmacovigilance, ISOP, we are very pleased to welcome all of you to the ISOP Patient Safety Day event that will be held today and tomorrow. The COVID-19 pandemic has unveiled the huge challenges and risks health workers are facing globally. Therefore, the ISOP engagement is to develop and share these safety awareness sessions to different audiences, patients, caregivers, and healthcare professionals, with the aim to increase safe use of medications and avoid medication errors around the world. It is now my pleasure to introduce our President, Mira Harrison, who will address you with a few words.
Hello, welcome to this ISOP webinar on World Patient Safety Day. My name is Dr. Mira Harrison-Woolrich, and I'm the President of ISOP. Thank you for joining us for this series of very interesting events to discuss what ISOP and our colleagues around the world are doing to focus on this very important day. World Patient Safety Day began in May 2019 at the World Health Assembly. All WHO member states endorsed the establishment of this day to be marked annually on the 17th of September every year. The reasons for this were quite outstandingly clear. If you look at these statistics that I've placed on the screen, there are many things that we really do need to address in pharmacovigilance. For example, 134 million adverse events occur every year in patients in low and middle income countries. 2.6 million deaths annually are due to adverse events. 15% of hospital expenses in OECD countries are due to treating patient safety failures. 4 out of every 10 patients are harmed in the community setting worldwide. So this issue, which is not just restricted to adverse events associated with medicines, but more generally to patient harm, it's not just restricted to hospitals, but also to community settings around the world. The aims of World Patient Safety Day are to recognise patient safety as a global health priority, to increase public awareness and engagement, to enhance global understanding of patient safety, and importantly, to spur global solidarity and action to promote patient safety. All of these aims, which were derived by the World Health Organization, align strongly with the missions of our society, the International Society of Pharmacovigilance, which is to protect patients from harm by promoting the safe use of medicinal products worldwide. I'd like to just tell you a little bit about ISOP, because I realise that many of you tuning in today will not necessarily be members, because we have opened up these events to everybody for free of charge. But our society, in summary, is an international non-profit making professional organisation aiming to promote drug safety scientifically, clinically and educationally in order to enhance all aspects of the safe and proper use of medicinal products. In this definition, we include all drugs, vaccines, and medical devices. And I should say that includes drugs which are sold over the counter and herbal medicines as well. And we aim to cover all countries. We currently have approximately 800 members in approximately 100 countries worldwide. We have regional chapters in Africa, Asia, Europe, Latin America, Middle East, USA, and Western Pacific. We also have a number of very active special interest groups. These webinars are being produced by our medication error special interest group, and we have other groups that discuss herbal medicines and women's medicines. So if you are interested in joining ISOP, there's plenty of ways in which you can contribute to drug safety by being involved in these regional chapters or being involved in the ISOP special interest groups. Do have a look at our international website, which is on the screen now, isoponline.org, and look at the membership page and do think about applying if you're not already a member. So I'd like to move now to how can we work together this year, 2020, to reduce harm to patients worldwide. It's a very important year in medicine safety with the current pandemic crossing our world. And maybe the first thing to say is what we're all already doing here at this meeting is participate in these World Patient Safety Day events to start to learn what's happening worldwide in your country, in your region, and across the globe. So let's try to become educated, first of all, on all the key issues affecting patient safety in our countries. For example, are there issues with access to safe and effective medicines? Are there issues with medication errors, prescribing issues, or compliance issues? Or are there, and this could apply equally, special and specific safety issues with particular medicines, devices, or vaccines? The next thing we can do is to remember to report suspected adverse drug reactions to all medicines, devices, and vaccines. In most countries, there's a national authority where you can report any adverse event, and this information is available online. As I was saying earlier, this year is a very important year because of the pandemic and issues with vaccine safety and medicine safety. So think about joining a professional society such as ISOP to collaborate and share information with your colleagues. And the next and perhaps most important thing I have to say about this is to start some conversations about pharmacovigilance, about medicine safety in your pharmacy or your clinic. I'd like to just share with you now one example of what ISOP has been doing to start these conversations about medicine safety. Throughout this year, we've developed the image which is on your screen now, which is an infographic about using medicine safely during the COVID pandemic. This was developed by a group of us within the International Society of Pharmacovigilance, and we wanted to try to communicate 4 key messages about using drugs and other medicines at this time. And you'll see on your screen there are 4 areas that we have focused on about where you access medicines from, how to act on side effects of medicines, how to stay safe and healthy. This is a really important point because a lot of people actually start using medicines differently in times of crisis and pandemic. And lastly, being aware of fake news, of wrong information, and directing people to information sites which can be reliable and can be trusted. We also developed this infographic in several different languages, and I will just show you some of these now, because we are aware in our society, although English is the official language of ISOP, many of our members around the world, of course, speak different languages. So I'm just showing you now on your screen the infographic in different languages. And these are all available on our website, on the ISOP website, which is now on your screen, and they also can be found on our social media platforms. Please do take a moment to have a look at them. Feel free to download them, print them out, and use them wherever you can to promote patient safety in your country. So just to wrap up this introduction, as the webinars commence, please think about the following things. This day, World Patient Safety Day, is a really important reminder to all of us of the need for continuing work on protecting patients from harm in all countries, wherever you work. Do enjoy and learn from the presentations by the ISOP speakers and by our international collaborators during the series of webinars. The WHO estimate that up to 80% of harm to patients can be avoided. That's such an important statistic because it means there is a lot of things that we can do. So implement what you've learned in these seminars, take them back to your country and implement them in your healthcare community. And again, please consider joining ISOP, and we'd love to have you join us in our society and become engaged in all the activities that we have to offer. And the last thing to say before we start the programme of events is please remember that every day should be World Patient Safety Day. Thank you for your time, and thank you for listening, and I do hope you enjoy the remainder of the events.
Now, let me introduce you to Dr. Ghita Benabdallah. She is pharmacist graduating from Monastir University School for Pharmacy in Tunisia. She began her career in a private pharmacy in Rabat, Morocco, during 5 years before integrating the WHO Collaborating Center, Moroccan Poison Control and Pharmacovigilance Center in 2001. Since then, she has been working in pharmacovigilance activity, focusing on promoting patient safety, preventing medication errors, and risk minimization actions. Since 2006, Dr. Ghita has been involved in different projects in collaboration with the WHO organization, World Alliance of Patient Safety, Monitoring Medicines Project, Uppsala Monitoring Center, and the Moroccan Pharmacovigilance Center to assess the ability of pharmacovigilance centers to detect and analyze medication errors and to expand the scope of national pharmacovigilance centers. She also contributes to the WHO guideline reporting and learning systems for medication errors, the role of pharmacovigilance centers. Dr. Ghita will present her conference entitled Management Drug-Related Problems within Pharmacovigilance Centers. We invite you to actively participate during this presentation. If you have any questions, please ask them in the chat on the right. We will be responding to as many as we can during the allotted time. The rest of the questions will be answered and published in our Q&A section within Patient Safety Day training on our webpage, isoponline.org. Without further preamble, please give a warm welcome to Dr. Ghita Benabdallah.
Hello, ladies and gentlemen. Good afternoon, good evening. I'm Ghita Benabdallah, pharmacist, and I'm working at the Poison Control Center and Moroccan Pharmacovigilance Center, which is a WHO collaborating center for strengthening pharmacovigilance practice. First of all, I would like to thank the International Society of Pharmacovigilance and the Colombian Pharmacovigilance Association for organizing this big event and allowing people, healthcare professionals, patients, general public to have access to a wide range of presentations having all the same goal, improving patient safety. The World Patient Safety Day is and will be a reminder to focus on improving health systems by increasing the culture of patient safety in a non-blame atmosphere. James Reason, the author of the Swiss cheese model, said that we cannot change the human condition, but we can change the condition under which humans work. And then we have to go from the individual approach to the systemic approach. The World Patient Safety Day was established on 17 September last year to be celebrated every year during the 72nd World Health Assembly of the United Nations, and I am very honored to be involved in this world event. I'm very pleased to give you an overview of the management of medication errors and drug-related problems within pharmacovigilance centers, which will show you the importance of pharmacovigilance in improving patient safety. So let's start with the history of medication errors, medication errors and drug-related problems within pharmacovigilance centers. The WHO program for international drug monitoring started in 1968, and since then pharmacovigilance centers are trying to prevent adverse drug reaction. In 1989 started the Moroccan Pharmacovigilance Centers receiving and collecting adverse events, and from this time we were already confronted to medication errors and drug-related problems because we are at the front line with a 24-hour on 24 systems of call, so we receive call 24-hour on 24. You should know that all pharmacovigilance centers collect and receive preventable ADRs and medication errors, but they were not aware of that. And it is only in 1999-2000 that started the awareness of the burden of medication errors with the report of the Institute of Medicine to Err is Human in USA, which stated that 44,000 to 98,000 deaths per year were due to medical errors, and among them 7,000 were due to medication errors. And this is at this time, from this time started the awareness and the awareness on the research on this field. So these are the definitions that we use in our pharmacovigilance center, and the medication error is an unintended failure in the treatment process that leads to or has the potential to lead to harm to the patient. And the preventable adverse drug reaction is an injury that is the result of an error at any stage of the treatment process. And then after that, in 2005, the Moroccan Pharmacovigilance Center started to focus on medication errors by doing some studies in its database that showed that 40% of ADRs were preventable ADRs, and also in ICU, in a hospital university, that shows that 7% of adverse drug reaction were preventable ADRs. And after that, the Moroccan Pharmacovigilance Center decided that it was time to go beyond classic pharmacovigilance. So what does it mean, going beyond classic pharmacovigilance? The first step was to start by improving the individual case safety reporting form to optimize the medication error detection through adverse drug reaction that were reported in our reporting form. The second step was the use of new tools. New tools that will help us to detect and identify preventable ADRs. So we developed a new tool, which is the preventability method, and it was a method developed by the Moroccan team. I just have a problem, it's not working. Okay, so this is the preventability method. So this preventability method allows systematic detection of medication errors within ADRs that are reported to our pharmacovigilance centers, and it is based on the identification of any well-known preventable risk factors that could increase the likelihood of ADR occurrence. And we have 20 defined preventability criteria. These preventability criteria you can see here are related to professional practice, to the drug, and to the patient. And when we are doing this preventability assessment, we ask questions. So we see if it is in incorrect dose, if it is in incorrect drug route administration, is it an expired drug medicine that was administered, was it a labeled drug interaction. So many things. We have to see each preventability criteria to assess the case. So the results of this preventability method, the assessment, could be preventable, non-preventable, or not accessible. When the case is not accessible, that means that we don't have enough information to do the preventability assessment. And once the case is preventable, it means that we have at least one preventability criteria, which is a yes. Once we've done the preventability method and the case is preventable, we have to classify the medication error. So we use the MCCP-MERP classification, and then we have to to perform the root cause analysis. This root cause analysis will help us to put in place specific and targeted risk minimization action that will lead to prevent the recurrence of such preventable ADR. So the root cause analysis, it is an investigation technique in 4 steps that will help us to understand what's happened. So first of all, we have to describe the event because we will understand what's happened, and then we look for underlying causes, is how is it happened, and then we need to understand why is it happened. So we look for contributing factors that lead to the occurrence of the preventable ADR, and then once the contributing factors are identified, we are able to put in place specific and targeted risk minimization action. For contributing factor, we use the Ishikawa diagram. Going beyond classic pharmacovigilance needs absolutely the sensitization of healthcare professionals to the concept of patient safety, to the risk that of ADR that are due to medication errors and other drug-related problems, and also to the importance of reporting adverse drug reaction and medication errors. Sensitization is done on site at the hospital university, and also during pharmacology courses in university, during postgraduate student internship in pharmacovigilance centers, and also we have designated a pharmacovigilance focal point in each department of the university hospital, and then we meet weekly once a week to discuss about ADRs, cases of ADRs and medication errors. Going beyond classic pharmacovigilance means also expanding the scope of pharmacovigilance. As you may know, pharmacovigilance concerns all medicinal products. It's going from medicines to cosmetic products, herbals, medical device, etc. And also in all contexts, all circumstances, from normal condition of use to medication errors, abuse, misuse, defective product or counterfeit medicine, intoxication, drug-drug interactions. So for an easy speaking, we used to use the term medication errors also for other drug-related problems as misuse, abuse, etc. In fact, WHO in its last definition of pharmacovigilance in 2002 extended its scope to include any other drug-related problem, which of course include all items that are presented here. And a little bit later, in 2010, the European Union extended also its ADR definition by including the term harm due to medication errors, misuse, and abuse. To display these new tools and to expand the role of pharmacovigilance to the management of medication errors, a global initiative has been initiated by WHO to display this information through a guideline edited with the help of the Moroccan pharmacovigilance team, WHO, UMC, and the UK National Patient Safety Agency. So now that we have seen and we have an overview of the history of medication errors and drug-related problems within pharmacovigilance centers, let's have a look on how we practically work in managing medication errors in pharmacovigilance centers. So we follow the same steps of the pharmacovigilance process. So we collect data, we do the case validation and case analysis. We put, once the case is validated, we put it in our database, and then we do the signal detection and signal validation. And once it is validated, the signal is validated, we perform the root cause analysis to put in place risk minimization action that will prevent the recurrence of ADRs and preventable ADRs. To be more precise, we will see together a real case. So we start with the collection of data. So here we have we received 3 cases. So it's a sum up of the cases. Of course, we have a lot of information about the case, but it is just for giving you an overview of the work. So we have received 3 cases. It was adults taking allopurinol, the Zyloric. They were taking 200 milligrams a day for a small increase of uric acid. One of them was taking 300 milligrams. One of them also was taking in association amoxicillin for pharyngitis, and they were asymptomatic, no arthralgia, just this small increase of uric acid, and they developed this toxidermia, life-threatening toxidermia, the DRESS syndrome. For both of them, the date to onset was the 27th day of the treatment. This is a range. So the second step is about case validation and analysis. So here you can see that this is a very, very important step in the pharmacovigilance process. This is the cornerstone of the pharmacovigilance process, the causality assessment, because we need it allows us to confirm the relationship between the adverse event and the drug to validate the case as adverse drug reaction. And after that, following this step, we have to assess the preventability in order to identify and to detect preventable ADRs. As you can see here, we have 2 situations during the collection of data. We receive cases that are adverse events. For that, we have to do causality assessment, but sometimes because we are doing sensitization to reporting medication errors, sometimes we receive cases that are reported as medication errors with harm. So for these cases, we do directly, we don't have to do causality assessment. They are already validated as medication error, and then we have to classify them. So in our cases, it was they were reported as adverse event. So we did the causality assessment to confirm the relationship between the adverse event and the drug. And we used the French method and the WHO method. And for the 3 cases, the result was probable. And then after that, we performed the preventability assessment. The preventability assessment is done. So you can see here the 20 criteria. So for doing this preventability assessment, we have to go back to the causality assessment. We use all information we've used for doing the causality assessment. We look for and we study the mechanism of action of the adverse reaction. We look for pharmacological properties sorry, of the medicine. We look at the information in SPC, and we have seen preventable criteria that are known that could increase the likelihood of this toxidermia as the incorrect dose. It is written in the SPC that the treatment with allopurinol should be used at the lowest dose possible at the beginning, and for our cases it was started at 200 and 300 milligrams, and it is well known also in the SPC. It is written that when we start with an increased dose, with a higher dose, it increased the risk of toxidermia. So already here we have one yes. So the case is preventable. We have seen also that it was a labeled drug-drug interaction concerning the association of amoxicillin with allopurinol. It is a well-known drug-drug interaction that increased significantly the risk of toxidermia. And also, in these cases, it was a non-indication, because it is written also that allopurinol should be prescribed for a patient with symptomatologic increased acid uric. So our cases were preventable ADRs. So after that, we have had to classify them. So the classification is done, first of all, function of the stage of medication error in the treatment process, and we have seen that it was a prescribing error. Then we need to classify function of the type of medicine. In our cases, we have the drug-drug interaction, the improper dose, unnecessary medication, and of course, there were others. And then we classify function of the seriousness. So it was the F category because it was the life-threatening ADR, and that required a hospitalization and a prolonged hospitalization. Of course, we put our case in the database, and we detected the signal because it was a cluster of case, and we validated the signal, and then we have had to do the root cause analysis to be able to put in place risk minimization action. So as you know now, we have the 4 steps. So the first step is to understand the proximal causes, to know what are proximal causes. So what's happened? It was toxidermia. How is it happened? It was the underlying causes. So the patient took Xyloric at a high dose, and we have also co-administration of amoxicillin. And then the third step, which is the most interesting step. So this step is to look for contributing factors that led to the occurrence of the adverse reaction. When we want to do this root cause analysis, we cannot do it alone in the Pharmacovigilance Center. The most interesting part is that we are collaborating with healthcare professionals that are in the front line with the patient, and also we do many investigations. We do many investigations to understand what's happened, and then we identified all these contributing factors that you can see. For example, we found out that we were facing an overprescription. We found out, of course, that there's non-respect of the warnings, that we have had a problem of dispensing, the healthcare professional having a lack of information, because we have had a delay in the taking in charge of the patient. We have 22 days, and problem in the posology. We have had also, we've seen that we have had a problem of self-medication, drug-drug interaction, etc. So with all these contributing factors, we were ready to propose risk minimization action to the National Commission of Pharmacovigilance. So the first The first risk minimization action proposed were regulatory actions. So we proposed that allopurinol become with a restricted prescription only for nephrologists, rheumatologists, gastroenterologists, cardiologists. Some of them, not all, because we are facing an overprescription. And also we decided it was important to send a dear healthcare professional letter to the healthcare professional to inform them on the risk of the rational use of the allopurinol, and also we propose to have an information shift on toxidermia in the drug boxes, and also to strengthen the application of the pharmaceutical legislation, because we have cases of self-medication. It means that it is sold without prescription from the pharmacy. So our requests were approved, and this is the letter, the dear healthcare professional, that was sent to healthcare professional with all information we wanted, that explained how to take it. So with insisting on the rational use of drugs and how to take the treatments. And also when it was approved to have this yellow sheet in drug boxes, and giving information on the first sign of toxidermia and what to do when we are facing first signs. After that, we decided that it was important to communicate around this risk, because it wasn't enough. And this is by doing a sensitization of healthcare professionals with the strengthening initial training on ADRs, strengthening the continuing education on toxidermia, delay of onset, etc., and information on the diet lifestyle measure, and very important on rational use of drugs, and also doing public and patient education via the media concerning the self-medication, etc. After that, we decided there's some point that should be implemented as a health strategies that are the must-do protocols. It was very important to do in-depth questioning, to have information on concomitant drug, history of allergy, etc., and inform patients on warning signs leading them to stop the treatment. Also to have a checklist on contributing factor leading to toxidermia, and of course always strengthen the continuing education. In conclusion, we can say that expanding the role of Pharmacovigilance Center to the management of medication errors is a success, because we have increased the number of medication reports, and it allowed us to put in place some effective risk minimization actions, and also to be an integrated vigilance system. It allows us also to strengthen our collaboration with other departments of the Ministry of Health and the universities also. And due to the WHO Collaborating Center for Strengthening Pharmacovigilance Practices, we are doing training course on the management of medication errors within pharmacovigilance centers. We are facing, of course, challenges, as the need to increase the expertise in analyzing and managing medication errors, and there's a need also to expand the role of Pharmacovigilance Center in managing medication errors, because many pharmacovigilance centers don't know that they are able to work on this field. We need also to strengthen the collaboration between national pharmacovigilance centers and the national and the World Alliance for Patient Safety, because a lot of work shared could be done. And for low and middle income countries, it is important to not duplicate systems and focus on a global vigilance system, because pharmacovigilance centers are able to manage medication errors and drug-related problems. Of course, we are facing limits. These are worldwide limits. We are facing underreporting and poor quality of report and the lack of patient safety culture. And we wish all that the World Patient Safety Day would increase the awareness of the importance of the culture of patient safety. And the last, it is also important to harmonize terminology to be able to talk the same language within with the National Pharmacovigilance Center, Patient Safety Organization, in order to share data and risk minimization actions. And thank you very much for your attention.